Thank you very much, Lawrence. So it's my real pleasure to present Alan Carson as the BMPA Medal Lecturer. Alan is a Professor of Neuropsychiatry at the University of Edinburgh. He's a consultant neuropsychiatrist and a lead at the Major Trauma Centre in the Royal Infirmary in Edinburgh. Actually, this talk could easily be on functional neurological disorder, which you've done a great deal of work on. But following a kind of long tradition of multi-specialisation, which I think is a real characteristic of neuropsychiatry in Edinburgh, Alan's going to talk on his other specialism, which is the neuropsychiatry of traumatic brain injury. So I will hand over to you, Alan.
Thank you very much. It's a real honour to be here. I'm going to talk about traumatic brain injury. So I do want to just say I've got a conflict of interest in that I periodically give opinions in court on cases of traumatic brain injury. Vaughn, we're about 20 minutes. Do you want me to try and finish on programme time or just use lecture slot? What would you prefer? Freestyle. Okay. Just want to start by just acknowledging Alwyn, Jonathan, if he's here today, and Ted Reynolds and others who started the BNPA. It's been my favourite meeting to go to consistently year on year, and I owe them a real debt of gratitude. And I also owe Alwyn a debt of gratitude as a unilateral mentor. By that I mean his books guided me all the way through my psychiatry training. I only spoke to him twice. It's only after I qualified that I actually got to know the man, but his books were just a sort of shining guide star throughout my career. And lastly, of course, Jackie, who puts everything together in such a fabulous way. If you do get a chance, thank her for all her work on behalf of the Society. Right, on to TBI. It is the single most expensive disorder we treat on the planet. $1 in every 200 of global productivity is spent on brain injury care, and we generally contrive to do it very badly in an unstructured, unplanned way. The majority of people with significant brain trauma leave hospital without ever seeing anyone trained above the neck, and that can't be a good start. So when trying to choose the lecture, I was trying to decide, shall I go for an in-depth review of a couple of narrow areas of TBI, neuropsychiatric interest, or a broad sweep? And I thought most of the audience probably see 2 or 3 cases a year perhaps, and a broad sweep of where things are at might be a better bet, with apologies to people who were expecting a detailed analysis of, say, psychosis. So it's a little bit more didactic than it might be. There's obviously nuance to everything I'm going to say. And I'm going to go quite quickly, so if you want to read some of the content, this review, I can say it's an excellent review because Lucia wrote 99.9% of it, clearly a rising star, and it kind of covers what I'm going to go towards. But the real key points we made is that in the last 15 years there's been a shift in thinking towards networks rather than lesions, and that you can only review TBI in the context of the people who suffer TBI, their social background, and most risks are bidirectional. So, quick note on epidemiology. Just in terms of incidence, the annual incidence of TBI is greater than the incidence of stroke, Alzheimer's, Parkinson's, and MS put together, so it is common. It's a disorder of males at all ages. Typically, this is American data, but it wouldn't be much different in any centre in Europe. Motor vehicle accidents account for a bit, but remember, that's not usually the person inside the motor vehicle. It's some poor sod on the outside, usually a pedestrian or a cyclist. Actually, motor vehicle accidents for people inside the vehicle are less common as a cause of TBI, and falls is the commonest reason, often from standing height, and it is growing exponentially because TBI is rapidly becoming a disorder of the frail elderly. We have a little peak in infancy, usually from parents, usually hapless dads, getting trusted with the baby for a minute and dropping them. There is a spike that needs to be separated out of non-accidental injury. Then it goes quiet through childhood, and a real emergence of young men, often young men with multiple social deprivation. We go quiet again in middle age, and then we start to rise as we become older and more unsteady. So classification. I just put up the Glasgow Coma score because it may be a few years since some of you have used it, just to remind yourself of what it was. Developed in 1974 in Glasgow, as the name would suggest, by Graham Teasdale and Brian Jeanette. The way Graham tells it is he was a young neurosurgical registrar, and Brian said, "Oh, would you mind just helping me over the weekend write up some data I've got?" I suspect he's underplaying his hand, but that was quite a good shout for him to get involved with. Couple of things about GCS just to be aware of. It's really the motor score that we're particularly interested in terms of predictions of severe outcomes. And secondly, it is not the lowest GCS at the day of arrival. Almost anyone who's knocked out will be transiently GCS 3. It is score at arrival at A&E or 2 hours that is generally used to classify. And thirdly, it's become a lot less predictive since about 1992. That's not because brain injury changed in 1992, it's because pre-hospital care did. And things like early intervention, intubation, pre-hospital, and early recording have disrupted the predictive value, because a lot of people now choose the lowest score recorded by the ambulance team rather than the score at A&E in terms of classifying injury. So, how might we classify injury? This is from an MRC, Department of Health, document concussion in sport that's been recently published. And as part of that, David Sharp, myself and Damien Bailey were asked to kind of say, look, how should the UK go about classifying brain injury? And what we conclude from the available evidence is we want to think of head impacts without symptoms. That might be something like heading a football. Concussive symptoms alone, so where people feel dazed after an impact. It's a bit difficult to know whether there was really a brain injury, but there might have been. And then classic mild traumatic brain injury, where there's been some definite loss of consciousness, but it lasts less than 30 minutes, GCS between 13 and 15, and a post-traumatic amnesia of less than 24 hours. But even within that, there's going to be quite a range of views. So when my kids were young, there was always parties and soft play areas, and inevitably some kid would fall from the frame, and you'd see them extensor posturing and landing, and they were clearly knocked out. And they'd lie still for 3 seconds. That's quite a long time if you're a watching parent. Then they'd get up, they'd have a gurn, as we'd say in Scotland, and they'd be straight back to playing. Clearly, if the same kid was lying absolutely motionless for 30 minutes, my heart rate would be going through the roof as I watched. There's obvious scales within these. We've just got to be aware that these are subconnections. And then moderate, severe, definite with the Mayo criteria, where we're looking at everything outside these markers, plus the role of imaging and imaging lesions, I think is the best current way. And we talked a little bit about the fact you've got to try and understand better the biomechanical forces of impact. We're very poor at understanding that. But the thing I'm particularly pleased about in this document is we managed to move away from thinking solely in terms of symptom production in terms of traumatic brain injury, but also associated inflammatory and metabolic cascades. Vestibular disturbance, it affects about 30% of injuries at all severities, and these things will interact. So you have a mild traumatic brain injury, pretty modest, but you get intense BPPV, so the world's spinning around. It's very natural to assume that this indicates you've really knackered your brain. That's going to alter your cognitions, it might alter your emotions. Symptom production is complex, but I'm mainly going to focus on the moderate, severe, definite group. And we can think in that in terms of diffuse axonal injury, shearing injury. It presents with diffuse vascular bleeds on MRI and on CT. We know, though, from pathology studies that where you've got diffuse vascular injury, diffuse axonal injury sits hand in hand. We can have contusional damage, a bit more about that later. And then we've got the classic worries of neurosurgeons, epidural bleeds in particular, largely arterial. They expand quickly, pressing on brainstem can cause death if not managed. Not all epidurals are arterial, however. You do, through fracture lines, get backwards venous seepage, which behaves more like a subdural. It's less damaging to the brain, and then we can have disconnection syndromes down the line. Quick word on imaging. CT is obviously the modality of choice in the acute phase because it shows blood products better. There really, in post-acute periods, there is no reason whatsoever to do a non-acute CT scan. If you're ordering a CT, it should be on an urgent basis post-acute. The investigations of choice are MRI, and they're MRI with SWI sequencing. Just to give you a sense of that, on the top row, we can see a standard CT. If anyone can see evidence of DAI on that, I'm impressed. There is some very subtly there. You can see on a standard flare sequence in the middle that you start to see some evidence, but with a gradient echo sequence, you see far more. And again, just making the same point, but this time flare versus SWI. That's really what we're looking at. There is something of a myth in brain injury culture about lots of injury being microscopic. That is true in the days of CT only from these sequences. You will virtually never see a definite brain injury that does not reveal itself on a sort of 1.5 to 3T MRI with SWI sequencing. I've seen one possible case out of the 6,000 cases I've been involved in my life. It is very rare. Can we predict outcome from these acute measures? Yes, a bit is the answer. This is data from both the crash trials and the impact studies. It's showing a combination of age, best motor score, pupillary reactivity, mixed with some of the early imaging findings and some of the biochemical abnormalities, have some degree of prediction. You can explain about 50% of the variance in outcome with these measures. The real key predictive measure, however, for most of the outcomes other than death is the duration of post-traumatic amnesia. Of course, it's not available when you first come in. You have to wait for it to develop over the passage of time. And it's strictly defined as the return of normal anterograde memory function. But I think it's important to realize that post-traumatic amnesia is really a global cognitive disorder. So if you're seeing somebody post-acute and they're saying, I had a head trauma, I can't remember what happened for the next week, but they drove their way home, whatever else was going on, they were not in PTA. PTA is marked global confusion. It can sometimes be interfered with in polytrauma by the use of analgesic medication. So you get somebody with a moderate head injury and a flail chest. It can be slightly difficult to judge. In that regard, clinical assessment is usually fairly accurate. So in other words, just checking, can the person remember where they are, why they're in hospital, what the story is, they generally can. If you give them a structured measure of PTA like the GOAT, they do disastrously badly, as they do on structured cognitive tests. The one giveaway that you're likely looking at medication-induced problems is they are not associated with retrograde amnesia, whereas PTA of any duration is. So if you get somebody who can remember point of impact onwards, then it's a blank. It's probably medication-related. Now, recently the American Society of Sciences, Engineering and Medicine sort of tried to move the goalposts a little bit in terms of classification. They kind of went back to the 70s and said, ooh, we shouldn't say mild, moderate, and severe. We should classify just according to GCS. You're like, well, no one's really been doing that for 30 years. So that was a slightly odd move, as some of their documents are. So, although some major studies are, you've got to be careful when you read studies from Centre TBI or Track TBI, they only classify according to GCS. So when they talk of mild injury, for instance, 30% of the people have lesion on CT scan. But what they also said, which I think was interesting, intriguing, is next generation neuroimaging and blood-based biomarkers will probably have a role. So let's sort of look at the next generation of imaging. So what we're really looking at is trying to image these white matter tracts. We can do that with functional anisotropy, neurite density measures, orientation dispersion, or white matter volume studies. And there's been a lot of work trying to do these. This is from a paper, the paper I'm just citing by Neil Graham. And don't want you to worry too much about everything. The one thing I want you to note is that none of these different ways of trying to measure this white matter integrity are measuring exactly the same thing. They don't correlate that spectacularly well. And the overlap with normal controls is significant. And DTI is altered by depression, anxiety, PTSD, opiate use, migraine, you name it, things we're all interested in. I don't think this is ever going to become the diagnostic measure people hoped. and it's not recommended in any major guideline. But I think it is interesting in terms of tracking outcomes and such things. And there is little doubt that DTI measures, particularly in the corpus callosum splenium, do correlate reasonably well with cognitive outcomes in particular. So it is measuring something, but I think it's maybe not going to be a differentiating measure that some people hope. And just as an added complication, it changes over time and age, getting better and worse. We can explain some of the worsening, maybe in terms of Wallerian degeneration, but the improvements we have to think about what does that really mean about what it's measuring. And lastly, when I started as a young consultant, enlarged cavum septum pellucidum was seen as the brain injury marker of choice. Roughly speaking, this paper just came out last week, it caught my eye. Essentially, you will have normal rates in about, I'm trying to remember the numbers exactly, 46% of brain injuries and about 48% of controls. It really doesn't distinguish. There are high rates of abnormality of this sign in the general population, and just to be cautious about that. What about the blood-brain biomarkers? I must admit, I find all this proteomic stuff goes slightly over my head. Lucia's made a fantastic job of unpicking it, and if you want to read about it, go and read her paper rather than listen to me twittering. But essentially, we can try to manage on markers that are brain injury specific. We can look at things that are exacerbated by TBI. We can look at general injury markers. And these markers are fluid and changing over time. It's not a static picture. And we might want to think of them in terms of positive predictive validity or negative predictive validity. So for example, S100B, which reflects blood-brain barrier damage, rises dramatically at point of injury and then reduces. It has quite a lot of value as a potential negative predictive marker instead of using CT for people arriving. You can just have a simple blood test, and if it's normal, the chances of any significant neural damage are really very slim indeed. So there are areas, I don't know if Camilla, who's speaking next, is going to have a view on that, but I'll be interested to hear what her take on it is. But also, can we predict longer-term outcome? That gets more complex. It's from one of Neil Graham's studies, well conducted, big numbers, so military personnel, looking at over 1,000 people in this cohort, well followed up. And we're comparing non-cranial injury, and this is military, so these are proper non-cranial injuries, you're either shot or blown up, versus TBI, versus healthy control groups. And what we see is that the TBI cases have higher rates of post-traumatic stress, higher rates of anxiety, higher rates of depression, poorer global health status, and poorer return to work. But can we predict that in terms of biomarker profiles? Well, here's some of the commonly used biomarkers. It's pretty unconvincing just looking at the spread. GFAP does have a predictive value, and roughly speaking, for each doubling in GFAP concentrations, you get double the rates of being out of work. So it's doing something, but I think it's probably going to be more of a research tool in terms of understanding than people coming to clinic, doing a quick blood test and sort of having a sense of where are we going. And again, just a reminder that mice and humans are different, and the profiles of these biomarkers dynamically over time varies between the two. So that's the injuries. What about the consequences? Well, traumatic brain injury is not good for you. If you survive the initial event, so you survive the first year, it is nonetheless associated with a substantial reduction in life expectancy that displays a dose effect. So the more severe the consequences of the injury, the more the reduction in life expectancy. A lot of people refer to the Brooks and Strauss papers. Just a couple of caveats to note in these papers. They're quite selected. You had to go to a level 1 trauma center to get into the cohort, then you had to move on to rehabilitation. That's missing out about 50% of hospitalized brain injury, which probably has better prognosis. So they slightly overestimate this effect. But more importantly, they don't control for socio-demographic status. And brain injury as a disorder of deprived populations, And just to give you an effect of the impact, roughly speaking, similar size gap in mortality between Glasgow and Edinburgh. So if you have a brain injury in Glasgow, hoof yourself along the M8 to maybe try and counteract, I don't know. Sorry, that's being facetious. But we do know brain injury has poor outcomes across the board neuropsychiatrically. I should actually just say, I meant to mention, in terms of that, sorry, my apologies. In terms of the people who got relatively good physical outcomes, walking well, some walking, most of that reduction in life expectancy is from neuropsychiatric disease, particularly suicide, which has a dramatic impact. Sorry, I meant to add that. As you go down the categories, more overt neurological complications come into the mix. But again, even this, CF Fasale doing what he does, which is to leverage this national Swedish cohort, which he has published some sensational papers, but I must have a frequent flyer pass on their database with, is more complex than it looks. This is from quite a nice Glasgow study looking at a very well epidemiologically based sample. But what I really want you to look at is their prior health status, which I've circled in green. About 40% of people who have head trauma anywhere in the UK have alcohol problems, but they also have significant physical limitations, prior neurological disease, all the things that dispose to falling and hitting your head. And when we're measuring outcome, we're not necessarily measuring change in outcome status, we're measuring global outcome status, so we shouldn't necessarily attribute it all to the injury. And what we really want to do to decide is it caused by the injury is to look for dose effects. So if we take one of the classic, well-established outcome complications of epilepsy, we can see a clear dose effect between mild injury and severe injury. This is from the Anigas data set. It's quite old, predates CT, so it comes with a couple of cautions, but the epidemiological capture is very, very good indeed. Mild, moderate, and severe, as used in this study, don't really correspond to what we'd currently mean by that, and essentially what they call severe injury is what we'd call moderate, severe, definite in Mayo terms. Mild injuries consistently in such studies show about a 1.5-fold increase in rates. I think it's highly unlikely indeed that that's actually caused by the mild injury. I think it's caused by the predisposing factors that predispose to mild injury. And in particular, when you control for alcohol consumption, that association disappears. The next one that people worry a bit about is listlessness and depressive-like symptoms secondary to pituitary dysfunction. I hold some responsibility for this because along with Peter Hutchinson and others, we published this paper based on systematic review of the literature, showed about a rate of 30% of people following TBI had endocrine dysfunction. We should have picked up the caution that there was no dose effect. This is just complete nonsense. The true rate is probably somewhere between 1 to 5 in 1,000. You will barely see cases. One of our delightful neurosurgical registrar's whole PhD was based on this, and he managed to find 3 cases from a consecutive series of well over 1,000 cases. It is hugely overstated and probably not much of an issue. On the subject of things that can be hugely overstated, at least in the newspapers, is the long-term risk of dementia. Now, I think there is a genuine effect, and I think it shows a dose response. I think the study by Jesse Phan's probably the best of the lot, but I think the evidence all points in the same direction, that TBI of significance, not mild injury, is a risk factor for later neurodegenerative disease, but it's very modest. It's about 1.5. Now, if we're thinking of dementia, there's about 30 to 40 risk factors of that severity, and the majority of the risk is genetic. So we do have to, yes, but no, if you see what I mean. The big peak you're seeing immediately after injury is reverse causality. So the typical picture is elderly person falls, has an injury that looks relatively modest on imaging, but has protracted period of confusion. The investigation of choice in that scenario is an informant history, and what you will almost inevitably find is a decline in memory function that people were swithering, should we be talking to the doctor about? And what we're seeing is early, just about to become clinical Alzheimer's disease. We get disruption of motor function as well as memory dysfunction, so falls become more likely, and it just all gets precipitated. So it's quite important because it has a huge impact on what's going to happen next in terms of recovery and triage of rehabilitation in the elderly. Let's move over to contusions. This was a study from 1930s California that Simon Fleminger brought to my attention. Really like to just acknowledge Simon. He's been very helpful to me over the course of my career, and I owe him a lot of gratitude for that. But what I really want to get across is the place of contusions is not random throughout the brain, but because our head is on a stalk, it is heavily located towards the poles of the temporal lobe and to the orbitofrontal cortex, whereas areas like dorsolateral prefrontal cortex are actually relatively protected from contusional damage. Now, when we're thinking of cognitive outcomes, we're essentially looking at contusions in terms of cortical disruption, and from white matter shearing, we're going to get sort of subcortical style pictures. So what sort of things might we predict? I can remember when I was president of the BNPA running a joint meeting with the Division of Neuropsychology and inviting John Duncan to give one of the distinguished lectures. I'm a real fan of John's work. I think it's sensational, but it wasn't without controversy. So I'm a believer. I will say that there were a lot of people in the audience that were strong disbelievers, so caveat emptor, if you like. But I am pretty convinced by his data on the multiple demand system, really measuring fluid intelligence, and most of what we mean while we're talking about bedside tests or psychometric testing of executive function are really measures of fluid intelligence, and they all cross-correlate. But some measures are distinct. Social cognition, apathy, and disinhibition do not correlate nearly as well. So these are going to be the areas, though, that we would predict would be affected in terms of contusional lesion. And people often call this the frontal lobe paradox, but I don't think there's any paradox, because it's exactly what you'd predict from lesion status. There's a slide stolen from John Hodges, which he kind of agreed, and it's just showing this very effect. Neural correlates of disinhibition. There are some psychometric tests like the hailing that give us a bit of an insight, and that's where we're going to see the action in contusional damage. But if we've got a brain with a modest PTA, less than 7 days, we're not going to have major neurocognitive disorder absent a major contusional damage. And we do see a lot of functional cognitive disorders in these populations anyway. And I just want to draw attention to this paper. It's come out, a lot of the hard yards done by Veronica and Laura on this work, but making a little diagnostic checklist, which I think is really helpful. This is retrospective testing, so again, comes with some health warnings. It needs proper prospective testing, but you've got to say it looks promising with that sort of area under the curve for picking up functional cognitive disorders. And I think when you're seeing people who are claiming really marked cognitive disruption with a PTA of 3-4 days kind of zone, no major single contusion, you should really be thinking functional cognitive disorders are likely explaining part of this picture, or there might be more nefarious things going on, as there sometimes is, of course. Let's move on to mood disorder. It's lovely to get a chance to show this paper. It's my second ever published paper. It's been downhill ever since in terms of journals, so I'm going to bloody well get it in here, even although it's not entirely relevant. But the diagnosis of depression in the context of brain injury is not without its difficulties. James helpfully did some of the hard yards on that, and making the point that apathy, which can look superficially like depression, doesn't actually come with a sense of negative anhedonia. And anhedonia, I'm an old school psychiatrist, I think anhedonia, rather than being upset, is the real core of depressive illness. And what I'm generally looking for diagnostically is people with anhedonia and who are just not doing as well as they should in recovery terms. That, I think, tends to highlight them most. But we also have to separate it from other things like discontrol, often through orbitofrontal lesions, the frustrations that go with language disruption, not being able to express yourself, the affective dysprosodias, where people's emotional life is normal, but their emotional expression is so disarmingly neutral that it's quite weird. But the bottom line is, when I was young, people thought that there might be depressogenic areas, particularly in the left frontal lobe. There's really no support for that. But the idea of lesion-specific interruption is not entirely for the birds. And using more modern network mapping systems, we do start to see evidence that disruption to either the salience network or default med network increases the risk of depression. And there's maybe some subtle suggestions that right-sided frontal lesions might actually impact a bit in terms of resilience. But it remains the case that the biggest single predictor of depression after brain injury is prior depression. Following that, it's global disability. So lesions are maybe there, but I wouldn't get too excited about them. What are we going to do if somebody is depressed? Well, I'm old school, I'm going to give them an antidepressant. And I would argue there's pretty good evidence that antidepressants work. This meta-analysis, I'm sure they must have been trying to apply for a major grant because they wrote it up as equipoise. But really, that's a reduction of 11 points on the HAM-D, which for the non-psychiatrist is a major treatment effect. So it's pretty convincing evidence, really, that actually antidepressants are effective. And that certainly corresponds with my clinical experience. What about psychosis? Well, I think in terms of the major psychotic disorders, I'm going to come on to them next. I think it's an interesting picture. But just in terms of relatively isolated delusions, I think they do occur at an increased rate after brain injury. And I'm thinking particularly of delusional misidentification, but also delusional misunderstanding of the world. So somebody sees a flyer in the newspaper saying you've won £1 million, and they actually believe it with a sort of pathologically falsified judgment. That kind of psychosis probably affects somewhere around 6% of people post-brain injury. I've highlighted Capgras syndrome because it has a little bit of autobiographical importance to me. The very first psychiatric case I saw as a medical student was an old lady who had delusional misidentification, such that when she looked in the mirror, she couldn't recognize her own face looking back at her. And the photograph is my daughter trying to represent that in photography terms. And we know that lesion-specific mapping, again, can give us some guidance into that. And what we see with the typical Capgras, which is really about delusions of replacement. So you look at a person, so I look at David, okay, sitting there, but I think it's not David. I think he's been replaced by an imposter who's coming into this lecture theatre for reasons slightly unknown. And it's not a prosopagnosia, because I think it's disarming how close this imposter looks to David. But what I'm not getting is the glow of familiarity, the sort of sense that I know David and I know him well. That's absent. And with using lesion mapping, we can see that there are deficits in the retrosplenium, which is the area closely associated with that sense of familiarity of faces, but also in right frontal areas, which are to do with judgment and imbuing significance to things. So we I think, can get these lesion-based disorders, and they're quite common. Often in brain injury, I find it's for place. Had one chap in the unit at Killian Welsh, I don't know if he's here today or not, and I used to run. And before it got rebuilt, it was quite old and dilapidated. That's not unfair to say. And the guy was convinced we were on a cruise ship. And I kind of pointed out to him that when we looked out his window, he could just see hard standing. He goes, well, of course, we're in dry dock for refit. And he looked around and said, I'll tell you, it bloody needs it, mate. But I think a separate question exists around, does traumatic brain injury predispose to schizophrenia or bipolar disorder? And this is complicated. There's no doubt that there is a huge association between the two. I think there's equally no doubt, just on clinical grounds, that the vast majority of this is people with schizophrenia coming by brain injury through deliberate self-harm, and we have a case a month of some poor soul, either in the prodrome stage or with known disease, jumping. But what about the reverse? Is that possible? Well, I think the bottom line, just in the interest of time, is that you don't see a dose effect here. When you start controlling for sibling environment, genetic factors, etc., we see no effect. And that certainly fits with my clinical experience. I've never seen a case where I've convincingly felt this person has schizophrenia secondary to their brain injury. I've seen quite a few cases where it's been undiagnosed. There's often been severe opiate abuse in the background, and they've popped up to clinics, and they've reported hallucinatory experiences pre-injury, but people have dismissed it and said this is all drug-related. They have their injury, they get taken off drugs, and they become frankly psychotic. But I think there's a bit of that, but I don't think there's much evidence to support the idea that traumatic brain injury is a risk for schizophrenia. Because if it was, it would have to be by network disruption, and you should have a dose effect, and that's been noticeably absent from the literature. Bipolar, slightly more nuanced. I do think you see a dose effect in bipolar. There is a subtle increase in risk that's been replicated. It's not dramatic. Again, just for the non-psychiatrists in the audience, the population risk of bipolar illness is about 1%. So these relative risks translate directly to absolute risks. And it goes up to somewhere between about 1.7 to 2%. So there's a change in absolute risk. To give that context, the risk of having had childhood aversive events in the development of bipolar illness is about a threefold increase in risk, so it goes up to 3%. But bipolar is heavily genetic. If you've got one first-degree relative with the illness, you have about a 14-fold increase in risk, taking the risk up to 14%. So there may be a subtle effect of traumatic brain injury on bipolar, but it's modest, and I would be looking into the family background. Managing behavioral disturbance. Don't reach for drugs automatically. It's like care of delirium, doing the basics, getting people mobilized, making sure they're not constipated, making sure you're doing your best to help orientate them to being in hospital is where the money is. If you do need to use drugs, try to use them with regular dosing rather than as required. As required, you tend to end up with excess dosing and chasing your tail. So titrate with routine usage. My own personal view, following one of Simon's early Cochrane reviews on this, is propranolol first, and then a low dose titrating upwards, usually of one of the atypical antipsychotics. I tend to use olanzapine or risperidone, but you know, choose your battle, don't really mind. Also be aware of the environment. It is worth in any neuroscience unit having a health and safety officer just check out the structured environment. If windows, for instance, open more than 10 centimeters, they're a distinct falls risk. I learned the hard way. I'm telling you so that you don't. Now, in the last sort of 5 or so minutes, structures of care. This is from the same American document, and it shows this rather convoluted structure of care. And as most documents do, they have acute care, and then somewhere down the line they have rehabilitation. And I'm going to suggest that is not a sensible way of doing it. There is a huge amount of coordinated evidence on this from a variety of documents that suggest that early, intense, team-based rehabilitation has far better outcomes and saves money. And I'm just going to show 3 slides from Nick Ward, who's a close friend at UCL, and really influenced a lot of the way I think about rehabilitation. And this is serial images of 2 cases with stroke. And the point I want to really make is that the majority of neural reorganization is happening in the first 31 days. That is a period traditionally in the UK where we leave people in a hospital bed without doing a lot to them. Doesn't mean you can't rehabilitate after that period, but it's a bit like having kids and saying, I'll talk to you when you're about 8. And we know from the Romanian orphanage scandal that wasn't a great plan. What's happening during that? Well, essentially, recovery, reorganization, is about neuroplasticity. It's changing the strength of existing connections, building new connections, but also pruning out disused connections. And that will happen in adjacent brain regions, but it will also happen in contralateral hemisphere. So a lot is going on. And like any brain activity, the more stimulus there is given to the brain during that phase, the more likely that is to happen. And we know that dose matters. we should be typically aiming to get about 3 hours of intense rehabilitation from AHPs per day post-brain injury. And I don't think we do that often across the UK. So I put forward the case that we know there are considerable cost savings downstream to early intense rehab, because remember the very first introductory slide, TBI is the most expensive injury we deal with, and that's because the long-term care costs are high. An inpatient stay across Scotland, population 6.5 million, we spend about 50 million a year, and that's not including the additional tariffs for theatre and ITU time. But just to give you some idea, to do absolute gold standard rehabilitation from day of admission across Scotland would cost about 8 million. There's actually very good trial evidence, not just from audit, but from randomized clinical trials of the cost savings. And if the trials are correct, if we did spend that 8 million, we'd save 585 million down the line. Now that might be optimistic per year, but let's say we got half of it. That's 250 million, that's more than we spend on neuroscience consultants in Scotland. Let's say we even get 10%, it's still 50 million a year. You know, that's more again. We could employ double the number of consultants for that. So my view is that we need to look at this science, and I persuaded the Scottish Government on this grounds to fund us to do this properly, at least in southeast Scotland. So our team consists of 2 neurologists, 2 neuropsychiatrists, neuropsychologists, a squad of AHPs, dietitians, social workers, some additional beds and nurses, and we corral all admitted head injury in southeast Scotland with a frailty score of less than 6 to the neuroscience unit. We've split our MTC, unlike anywhere else, into neuroscience and a general MTC, because I think neuroscience nurses are critical to the care of brain injury patients. And from day of admission, you get joint care between the neurosurgeons who keep you alive, and let's face it, that is rather important, but between the neurologists and neuropsychiatrists and team actually assessing the damage and rehabilitating you actively. With this model, in terms of the standard KPIs for trauma across Scotland, we perform at 3 standard deviations above the rest of Scotland, and I would suggest above most of England as well, because it's the same KPIs. We've actually reduced length of stay despite taking 3 times the number of patients, and that's because bed days are quite important. The more patients you take, the shorter the bed stays are. Hopefully, because we collect proms on everyone, soon be able to determine whether we are making a difference. But having worked in the service pre and post, I am pretty convinced we are having a dramatic impact on what's happening, and it is highly enjoyable work. And following various meetings, this has now been adopted as the commissioning model for England, with a bit of detartanisation of how we do it. And if you're interested, you read this paper by Lucia, Mike, and a cast of thousands. I must say, Mike Dilly is very, very good at this kind of stuff. So, closing comments. Obviously, it's nicer not to have this happen. What do we know about prevention? Well, the question always people ask me is, do helmets work? Yes, they do. Unequivocally, they will reduce the rate of injury. But helmets only come into action once you've had an injury, and it is far better to take action to prevent these injuries happening. So if we look at Amsterdam, for instance, which has one of the highest cycling rates in the world, also has one of the lowest helmet rates, and it has one of the lowest TBI rates, and that's because all the measures are taken to prevent the accidents in the first place. In the UK, we very much put the onus on the individual rather than the perpetrator. And the perpetrator for head injury are 2 things: their alcohol and their cars. Conflicts of interest. I have a large wine collection and I love the stuff. I do feel my future destiny is falling down the stairs after a glass too many one evening, and that I'm going to have to just take my chances on. But I object to taking my chances on car travel. Other conflict of interest, I have 2 Porsches and a Ducati, but I do drive them sensibly. And I just want to show this data from Edinburgh, where we reduced the speed limits in the inner city from 30 miles per hour to 20 miles per hour. We saved 332 lives a year by that measure. So the next time you see some district councillor coming on, usually with red trousers and cheeks of exactly the same sage, blurting on about how this is an infringement of their liberties, the question that they should only ever be asked is how many children have to die so that your journey time in an urban setting is 30 seconds less? My answer is 0. But you know, it's a free world, but they should be forced to give their answer, because there's no question this saves lives. So I want to conclude that there are always 2 critical questions in TBI. What is the nature of the injury? Should be specifying it in terms of standard injury markers, duration of loss of consciousness, GCS, duration of post-traumatic amnesia, and findings on imaging. But equally, and almost more importantly, we should ask what is the nature of the person injured, because that's often going to be as telling as to what happens next. I've managed to catch up a bit of time, so I hope I can just be indulged in giving a little bit of thanks. My brain injury team in Edinburgh, Laura, Patrick and Ingrid, I couldn't ask for better colleagues, and the whole army of others who work with us. It's a squad of 20, it's an absolute team effort, and they're an absolute pleasure to work with. I'd like to thank my wider friends in the FND world who've made my consultant life an absolute joy, particularly John, who I've worked with for the last 30 years. The people who've come through our group, those who trained me, particularly Mike Sharp, Charles Warlow, but also Eve Johnson, who, although never trained me, funded all my higher training and pretty much let me do what I like, which with age I realised was such a remarkable generosity of her, and I really thank her for that. But all the people had an input into training, Killian, Ali, Lorna Langro, Lorna Torrance from the RFU when I worked there, the staff of DCN, not just the clinical staff, the nurses, the cleaners, the porters. It's a fabulous team, and just people who've shaped me along the way. I meant to give a particular shout out to David Sharp along the way, who's been a fabulous sort of colleague stroke sparring partner. We've kind of started from opposite poles 20 years ago, and we've gradually started to meet in the middle, but having somebody with a different world view is kind of more valuable almost than having somebody who just provides an echo chamber, and yeah, it's been fantastic. And the rest of the names are there. Just like to thank you all. And I'd particularly like to shout out Mark Hallett, who's been an incredible mentor over the last 10, 15 years to John and I when we wrote the handbook together and then set up the Functional Neurologic Disorders Society. And I'll stop there, but with a little flyer for Mahinda's epilepsy meeting. Thanks for your time.
I'm aware of the time, but I think we probably have time for a couple of brief questions if you have them. Lady at the back.
I don't know whether you can hear me without a microphone.
You maybe better use a microphone for the hybrid people. But yes, I can hear you loud and clear.
Is that better?
Yeah.
Judith Allinson. Just so that you know, as we did start with the rapid access rehab units in MTCs in England in 2012-13.
Yes.
My question is twofold. You didn't mention any rehab doctors in your team, which seems a shame. But more importantly, I'm interested in this 3 hours which come of early intervention. I'm certainly very supportive of the idea of early intervention. But some people who are very distressed and in PTA sometimes don't cope with lots. So I'm interested, it depends how you measure and what you're measuring for those sort of 3 hours of early rehab.
So several different things in there. Firstly, with apologies, Paul Carroll picked me up on that yesterday. I was tending to talk with reference to my team. We did suggest that rehab medicine could also be involved for various local political reasons. That didn't happen. In the document I was referring to, it does suggest rehabilitation medicine could be part of such teams. So that should be acknowledged, and my apologies. It is always offensive when you fail, so I'm sorry about that. Very much part of the picture. I think the hyperacute rehabilitation units, the ones I've visited anyway when we were planning our service, were doing something slightly different, because they did still tend to start after the initial acute phases, whereas we start in ITU. So I think, you know, these are all evolutions, and, you know, lots of thinking, and including the presence of these hyperacute, and these are the units that gave the early data for cost saving. So I'm certainly not dismissive of these at all, and if I gave that impression again, apologies, definitely not. But I think we can go earlier still. As to the early thing, actually, I think you can start the rehabilitation process when people are in PTA, and we generally can, and such things as starting mobilization with physiotherapists, starting occupational interventions work very well during that phase, so I do think you can rehabilitate them. The 3-hour idea, of course, like all ideas, it's a slightly artificial construct. The data is purely linear. The more you do, the better. So 6 hours is probably better than 3, but 3 hours was a sensible target we used for selling the idea. But I would say, and this really came more from the Glasgow Spinal Unit, where they do everything in the same ward, as I'm sure you know, they start straight away, and that's what we wanted to do for TBI. And I think we've established you can do it, and you can start that process in ITU.
Thanks. I think it's all about what it is you're calling that. I mean, of course, you start by seeing people on day one, and you know that's what we do in some places.
Yes.
But it's just a case of what you're doing. So thanks for explaining on that.
And I'm certainly not trying to pretend we're the only pebble on the beach. We obviously took ideas from other people. I'm just describing how we do it.
Question here?
Thanks, Alan. That was a fantastic talk. My question is about PTA and really about the nomenclature. I find when you go into the general hospital to assess brain injured patients, the concept of PTA often seems to cause a lot of confusion, and not only to the patient. And as you said, it's really a kind of shorthand for a global cognitive deficit. But of course, we call it amnesia. We don't call it a global cognitive deficit, and I think that does cause problems. So my question is, do we need to call it something else? And perhaps beyond that, could we actually file it under acute delirium, with which obviously there's a considerable overlap, or do we actually still need to have a separate concept?
I think we need a separate concept, because I think it probably has a different underlying pathology, that it's about disconnection, whereas delirium is really about attentional problems. So I think the core thing is, for instance, PTA does not show the same 24-hour cycling as delirium, and it tends not to be associated with hallucinosis or illusions, which would be common in delirium. So I think it is a different thing. But yes, if I had my time again, we would stop referring it, because I think the amnesia aspect directs people solely to memory function, whereas I think it's wider, and I would be calling it something like global cognitive disruption, because I think that would orientate people to what it is. And I think it does need clinical assessment. I think the confusion often comes when people get overly hung up on using structured measures. And this is a double-edged sword, because I like the fact that particularly OTs are trying to measure this routinely in trauma centres. But these are tools to assist. They're not tools to govern. And I think there is room in complex cases for an experienced clinician saying, actually, this is not the time to use that. These people are out of this global cognitive disorder. But yeah, I agree with all you say.
Thank you very much. I think for the interest of time, we're going to finish there. I think it just leaves me to present the BMPA medal to Alan. I wonder if we could...
Thank you, everyone.